to AC's replay webinar, Secrets and Pearls of Rheumatology. We're excited to have you join us and appreciate your commitment to staying informed and advancing your expertise with us. I'm Ryan Massey, and I'm a rheumatologist at the University of Michigan, and I will be moderating tonight's session. I'd like to begin by saying a very special thank you to our speakers, Professors Janet Pope and Walter Chatham, whose dedication and expertise make this session possible. They'll be answering your questions and sharing invaluable insights live at the end of this session. Dr. Pope is a professor of medicine at the University of Western Ontario and division head of rheumatology at St. Joseph's Healthcare in London, Ontario, Canada. She's internationally recognized for her expertise in systemic sclerosis, lupus, and rheumatoid arthritis, with over 500 peer-reviewed publications and numerous book chapters. She has received multiple honors, including Distinguished Investigators Award from the Canadian Rheumatology Association, Rheumatologist of the Year from the Ontario Rheumatology Association, and the Dean's Award of Excellence in Research. She's also been inducted into the Canadian Academy of Health Sciences and named an honorary EULAR member. Her research focuses on clinical trials and epidemiologic studies in rheumatic diseases, and she's passionate about mentoring, having guided more than 125 trainees through her career. Professor Chatham is a professor of medicine and chief of the Clinical Immunology and Rheumatology Division at the University of Nevada in Las Vegas. He previously spent 37 years at the University of Alabama at Birmingham, where he served as clinical director and rheumatology training program director. Professor Chatham is a recognized expert in lupus and autoimmune disorders and has received multiple awards from the American College of Rheumatology, including Clinician Scholar Award, Clinician Scholar Educator Award, and a designation as an ACR Master of Rheumatology. Finally, before we get started, just a few reminders. Please use the question and answer field to submit your questions. Our staff is behind the scenes, making sure that the panelists receive your inquiries in real time. So without further ado, let's get started.
Good morning to everyone. Welcome to this exciting session in Secrets and Pearls of Rheumatology. My name is Angelo Gaffo from the University of Alabama at Birmingham and the Birmingham VA, and I'm here with Dr. Ryan Massey from the University of Michigan. So a reminder of a couple of housekeeping items. Please silence your devices. And we have decided on this session to save the questions until the end after both the speakers have presented at the end of the session. So I'm going to now pass the microphone to Dr. Massey to introduce our first speaker.
Hi, good morning, everyone. I am Ryan Massey. I'm from the University of Michigan, and it's my distinct pleasure to introduce our first speaker, Professor Janet Pope from the University of Western Ontario, who's going to present on Secrets and Pearls of Rheumatology and Connective Tissue Diseases. Dr. Pope has had an illustrious career. She's published over 500 peer-reviewed articles on scleroderma, lupus, and rheumatoid arthritis, has received numerous accolades, including being inducted into the Canadian Academy of Health Sciences, which is the highest achievement for a healthcare professional in Canada. Dr. Pope.
Great. Thank you. And first of all, I'd like to thank the ACR for inviting me for this. I feel honored to talk about some tidbits, and just to know it's my opinion. If you don't agree, that's quite okay. Some are non-controversial and the odd one is. First thing. And second thing is thank you for coming. We're competing with a lot of interesting things such as the plenary. So I hope you'll get some good clinical take homes. So these are my disclosures. So I really, on objectives, really want to just talk about some areas. I'm concentrating on CTD, a little bit else in there, and some pearls that might be important for your practice as you go. So first we'll go for SLE, and of course the patients have consented to the various rashes and features of lupus. So the first pearl is not all lupus rashes are created equally. And I'll tell you two pearls within that pearl of what I mean. So different rashes have a different chance of the patient having systemic lupus, and the frequency within systemic lupus of these rashes can vary as well. So I made a little table. There is a range from the literature, but basically if someone presents with discoid lupus, 5 or 10% will have systemic, but within systemic lupus, 1 in 4 patients might have discoid. If they present with subacute cutaneous lupus, about half are systemic. And I'm going to tell you, it's kind of hard to tell if they're systemic or not because they might not meet classification criteria, but that's not always how we diagnose. But about half are. But within lupus, maybe 1 in 6 will have subacute cutaneous. If we look at a malar rash, as long as you're not misclassifying rosacea or other erythematous rashes, and even some discoid rashes can look in a malar distribution for sure. But a malar rash, if you have it, it would be that you have lupus. So it's basically 100% of women or men with a real malar rash have lupus. And you can see in the picture I'm showing here, she's not sparing the nasolabial fold, but is photosensitive. She's Smith positive and she does have systemic lupus. She has a little overlap with a couple other things as well. So that's just sort of an interesting way to look at it. This is not for prime time to discuss, but a really nice journal article from Dr. Worth and her group who presented the other day, tidbits on cutaneous lupus, and there's quite a few different kinds. Also, the pathology of lupus. So as a tidbit, learn the words. So the words help us. So interface dermatitis, follicular plugging, lymphocytic infiltrate, and we'd like them to do staining. So lupus band test or staining for IgM with or without C3, or IgG. Now, IgG is more specific than IgM, but IgM is more common, and IgM plus a C3 staining is really quite helpful. So I'm going to have a few learn the words on pathology as we go. Okay, the next pearl is rashes are also not created equally between inflammatory myositis, so dermatomyositis rashes, and lupus rashes. So a couple things are, in general, a lupus rash will be between knuckles, so where you might wear your rings, so between knuckles, and a dermatomyositis might be on knuckles, Goitron's sign or Goitron's papules. Goitron's papules are on the knuckles, not always all of them, and they're raised. Goitron's sign isn't raised. But if it's bad enough, like that picture where I say, what is it? You don't know really, was that lupus rash or dermatomyositis rash? And if we biopsy it, the rashes in both of those that person could look either, it could be compatible with those follicular plugging, interface dermatitis, etc. So that patient, if you look really carefully, you might say, well, maybe that some PIPs are whiter there and maybe it's a lupus rash that went more disseminated, but it's hard to know. But in rule of thumb or finger, it's lupus rash in between knuckles, dermato on knuckles, and then who knows what happens. The other thing is clinical pearl. This is called a lupus rash, but it isn't. And I think some of you would know there was a lot of talks on sarcoid yesterday, so some of you might have gone to it. So lupus pernio is from sarcoidosis. And it likes to be in areas where lupus rashes might be. So face, neck, upper arms. It can be all over the place too, fingers, etc. And it can look quite different. So those two patients are different. They look different. One I got from the internet, and one is my biopsy proven patient. So the words here are you're looking for giant cells, so Langerhans cells. That is not pathognomonic and it is not specific, but it is common enough. We're looking for our granuloma in sarcoid, but just remember, if you're wondering about a rash, maybe it's on the hands or something, mycobacteria, you say, oh, do you have meridium because your hand's in an aquarium or something like that? So if in doubt on these rashes, biopsy. If in doubt, biopsy. Okay. Most rashes in our patients with chronic rheumatic diseases, adults and kids, are lymphocytic. There are exceptions. So CTDs are lymphocytic rash. When we go to vasculitis, like rheumatoid vasculitis, it's not necessarily lymphocytic. But when you go to certain rashes, they're neutrophilic. So Sweet syndrome would be a neutrophilic dermatoses, and it's not the only one on there. And then, of course, EGPA rash could have lots of eosinophils. So if you were writing an exam as a trainee or your update exam, just pick lymphocytic for most CTD rashes and you'll be right most of the time. So Sweet syndrome, especially neck area, it can be elsewhere. It is diagnosed by a biopsy. These patients are systemically unwell, and there's all sorts of associations. I'm not going to vex you about vexus, but there's a lot of associations now with neutrophilic dermatoses. So that's about it for the pathology side of rashes. We're going to move on to lupus nephritis. So you got the new guidelines on the non-lupus nephritis treatment at this meeting, but lupus nephritis we like to classify. Some will actually actually have a class 6, which is a damage. But in general, for lupus nephritis treatment, we're talking about clinically relevant, at this point in time, clinically relevant, either class 5, which is a lot of proteinuria, nephrotic range, etc., nephrotic syndrome, or class 4, or some mix of that. They're the patients that might progress. So this is one of my patients with active lupus nephritis, and you can see he consented for the picture, but you can see he looks like he has a heliotrope around his eyes, which he does. He is lupus, not an overlap. He's got a malar rash. He's got hair loss. He's had mucositis, serositis, inflammatory arthritis, and he's been really sick. But what is a important clinical pearl is we can't not talk our radiology or nephrology colleagues. We must talk them into the first time having a biopsy. Why? Because the biopsy is important as a clinical pearl. Acuity and damage. So what's the proper diagnosis? What class or stage are they in? What's the prognosis? Is there a lot of damage or not? Or is it all APS or something? Because that can mimic our lupus nephritis. So a biopsy is important, and the biopsy needs a plain look. So under the regular microscope, it needs EM to actually know what's going on at the membrane, the foot plates, etc. But it also needs immune fluorescence. So a good biopsy should have all those components. And as you know, the guidelines, both the ACR and the kidney disease group guidelines say, please biopsy. It might be more controversial for a repeat biopsy that again can tell you prognosis, and it can help to verify diagnosis if they're not responding to treatment. Have they morphed? Is it all damage, etc.? But here you'll hear many things, including late breakers, etc., the plenary yesterday on liquid biopsies. So the goal is, it's not a pearl yet, but that we might have on urine that we can actually tell what's going on. So moving on, this is my opinion. So this is a pearl that I think is a pearl in evolution, but the treatment of lupus nephritis may be improved by both SGLT2. That is not at all questioned for the proteinuria. There's RCTs in non-lupus membranous nephritis showing improvement in proteinuria, and CKD, improvement in renal protection, less proteinuria. So everybody with some kind of proteinuria with lupus should be on an SGLT2. But that's not the controversial part. You will see at this meeting, there's been some publications as well that GLP-1 also has a role. So GLP-1 in general in diabetics and in non-diabetics is good from atherosclerotic perspective. It's also good for lessening renal failure, whereas the SGLT2 is good for proteinuria and preserving renal function that way, and good for congestive heart failure. So you will see them being combined, and it's going to happen in lupus nephritis, is my clinical pearl prediction. And we did a nice editorial way back when showing the value and protection of SGLT2. And because there's lots of databases, trial emulations showing why they're important, and they are certainly used beyond diabetes. And then GLP-1, again, access will be an issue. So GLP-1 looking here as well in lupus, but also if you look at the line with lupus nephritis, you can see it's protective for renal progression. I must say though, these are studies, observational, non-randomized, where patients also have diabetes or obesity. That's why they're getting a GLP-1, but it is helping their lupus nephritis. So I think that's a pearl for the future, but I think it's coming. The next pearl in lupus nephritis is you can at times taper and even at times fully discontinue immune suppression. But the two key words are slow, and you want them in remission, renal remission, and other systemic lupus remission. I'm not saying serological remission. I'm saying clinical remission and renal remission by how you look at it. And the reason that it's slow, lots of observational studies out of Toronto, out of here in the US, there's lots of observational studies showing that this can be done slowly. The guess is after about 5 years. So it's kind of like an ANCA vasculitis. After about 5 years of doing super well, can we start to get rid of the maintenance therapy or taper it? And the reason it's for a while, because when lupus way back when was a loser, it wasn't a winner. So it was withdrawal of immune suppression and nephritis. And these patients didn't have to be in long-standing remission. They had to be in clinical lupus nephritis remission, but there were more flares stopping therapy. So they withdrew maybe too early and maybe not slowly enough. So just keep that in mind. But you might want to keep them on, if it's a second lupus nephritis flare, you might want to keep them on immune suppression indefinitely. Okay, the next clinical pearl is really the treatment of lupus nephritis class 4 or 5 active nephritis is going to be polypharmacy because it needs to be. So your MMF, or in some cases cyclophosphamide, hydroxychloroquine, controlling hypertension, fluid balance, proteinuria, so your SGLT2, your RAS, your ACE, your ARB, etc. And they're controlling blood pressure, controlling lipids, and then also you will have on whatever you get access to of belimumab, voclosporin. Lots of countries would do tacrolimus instead because they don't have access. There's a nice RCT of tacrolimus working and lupus nephritis, as well as back in 2013, an old trial that showed it. Obinutuzumab and anifrolumab will read out, and many, many more drugs will read out. So why? Because basically chronic renal disease in lupus from the TriNet-X database presented last year at 2 years was about 1 in 5 people. By 5 years was 1 in 3. CKD is an unacceptable outcome for my patients in lupus nephritis. So we have to do better. That's why. What about inflammatory myositis? So again, this is one of my patients who consented. So you can see her Goitron's sign. It's not raised. If it was a bit raised, it would be Goitron's papules. You can see her heliotrope. So this might be controversial, what I'm going to say next, but I think the literature is backing it up. You do not need to do above ordinary cancer screening in inflammatory myositis in all patients. It used to be all patients, and you would screen actually annually for 5 years and PET scans and stuff like that. But there are some patients where we need to do it. So this is maybe I'm ahead of the literature, or maybe I'm slightly disagreeing with the current literature. But why? Because you want to stratify by risk. So we would stratify by risk if someone's older, huge weight loss, dermatomyositis, and can't swallow. So severe disease. I'm going to be looking for cancer. So we're going to stratify by clinical risk. But here's why. The cancer risk is almost solely, not solely, but almost solely increased, as you know, in your TIF1 gamma and your NXP2. And the picture I showed, that's an NXP2 patient with breast cancer, and she's doing very well right now. And then these other antibodies, including ones I've never heard of, like HA and ZO, all these other antibodies are lower risk. So what you want to do, this is from an article that I've taken it. Sorry, I forgot the reference. But you want to kind of look at what are the cancer risks. Now, if someone hasn't had their PAP and their mammogram, or they haven't had their stools work up for colon cancer, do the cancer screening in your country that's recommended. But I'm not going to work super duper hard if my index of suspicion and the antibodies show it. If I have someone with 10 years of dermato that's mostly in remission, hasn't lost weight, I'm not going to do super extra cancer screening. Early on, you're not always sure. So older age, weight loss, ulcers, more severe disease, they're all risks, and certain involvements. So the other thing that is a little bit interesting, which I didn't know, I read about this, and so I'm telling you what I learned as a clinical pearl. Skin biopsies and dermatomyositis often have the same pathology. It's a read the words again thing. So Goitron's, your V-neck cape rash, not that people biopsy a heliotrope, but even mechanics hands can all have the same description. And to us, they're not at all the same rash. So it's kind of interesting. So interface dermatitis sounds like lupus. Vacuolar changes, inflammatory infiltrate, which we now know as lymphocytes by another pearl. Mucin deposition, and you can have some differences. You can have vasculitis. Dermatomyositis, if it's a muscle biopsy, is vasculitic. Polymyositis is not vasculitic. So I'm talking about basically dermatomyositis findings. But if I had a patient and I said to the pathologist, this is lupus, they'll say, okay, compatible with lupus. If I said, I think this is myositis, dermatomyositis, they might say compatible with dermato. So be careful what you ask for. Give as much data as you can. We're going to talk about labs, and I really think 1 or 2 lab things will be controversial, but not most. So we know the ANA. Who is able to get a pattern on the ANA? Can I have a show of hands? So maybe only about a quarter can get a pattern. And who's able to get a strength, like either a dilution titer or a number? Who can get a strength? Almost everyone, but not everyone. So Just like in diabetes, if your HbA1c is 12, you're more apt to have diabetes than if your HbA1c is 6.2. So just like a very strongly positive ANA is more likely for us to get kind of excited about it, which is why we like the strength of it. And certain patterns get me excited at least. Rim or peripheral, not very common. Centromere and nucleolar, some are a little bit more. They change our thinking of what to look for. This is, to me, patterns are important. And, a borderline speckled, I just want to reject that referral right now. I'm going to tell you. Unless if the pre-test likelihood was 0, then the post-test likelihood will be 0. I don't want to know about the rosacea or something. Okay. So first of all, and I think in this room we agree, but this is to disseminate to the non-converts, the non-rheumatologists, and frankly to our great, smart general internist colleagues. Don't order an ANA if there's a low index of suspicion, because it's not useful. So if you've done a history and a physical and you say maybe it's lupus, by Bayes' theorem, if it's positive, it makes that more likely. If I say this is 100% not lupus, the pancytopenia and the fluffy stuff in their lungs and the rash is because they're intubated, they're on 10 drugs and they're super sick. That is not this is say an 88-year-old man is probably not lupus, even though you'll hear on an epidemiology presentation here that men often get, if they get lupus, their peak is in their 60s, which in women, it's more like 30s to 40s or to 50s. So that's the first thing. But the other thing that I think, if you're doing it for research, maybe I'll let you do it. But basically, don't repeat a positive ANA. You only need one ANA positive in your life as a classification criteria. So there is only one exception, because I was talking to a pediatric keener here. If someone has pediatric autoimmune liver disease, apparently the hepatologists and pediatrics treat till the ANA is neg. In the adult world, one ANA ever. That's it. It's your quota. I mean, if you had it done 20 years ago for no reason and now they come in with a rash and mucositis and they have a pericardial effusion, go for it. But a positive ANA need never be repeated. Let's move on to ENA. So this is really a bugaboo, and I'm trying to save you consults because we're all busy. If you get an SCL70 positive patient referred to you with a negative ENA, just reject the referral. Say, sorry, it's a false positive. If you get an RNP positive patient with a negative ENA referred to you, it's a lie. It's the lab. The labs have an error rate around when they start diluting. A negative ENA, the only time a negative ENA would make me order another autoantibody is Rho. I might order a double-stranded DNA because the ANA is positive, but in the ENA, because Rho can be nuclear or perinuclear. Think of ANCAs. ANCAs are perinuclear in general. They're cytoplasmic and perinuclear. Rho can be in or out, but everything else, SCL70. And I put on some references that in general are supporting what I'm saying. So, and Rho is positive. Because the other thing is you don't need to repeat an ENA unless if new stuff comes. I have truly had lupus patients that go on to get a Sjogren's overlap, or I've had a scleroderma patient that then develops something else. So I looked again, but I do repeat ROs, RO or SSA, in women who have lupus or are contemplating pregnancy, because now I'm kind of thinking about two individuals, not one. So I'll spend the money. Or if they're already known to be Rho positive, and they are pregnant, that because we want to follow for congenital heart block risk, etc. So ENA, you can reject all those referrals. You can say, I was told to reject that. Okay. If the ANA is negative, do not order an anti-double-stranded DNA. Waste of money. We have loonies, but you actually have greenbacks, you have euros, you have other things. So it's a waste of money. So basically, we have convinced our lab to stop doing double-stranded DNA when the ANA is negative, because the only place where you get a double-stranded DNA is in your nucleus. Single-stranded DNA is noise. We might all have a single-stranded DNA after a viral infection transiently. So ANA negative, stop ordering. And it's not us, because we get the referrals coming to us, but really the lab should stop doing that. So the double-stranded DNA is a false positive. It's noise. Why? Because the old-fashioned double-stranded DNA being totally specific for lupus was to liver cells from sheep. On the kits, there is noise around that. So it's not as specific as it once was. And again, this is where the general internists send the patients and I say, well, why'd you do it? Like they obviously have gout or they have mechanical back pain. So why did you do it? They don't know why either. They blame it on the trainees, but I think it's the attendings. Okay. We're moving on to a few other pearls. So negative, this, I'm going to just say it's controversial and I do research. So if you want to spend money and it's for research and you pretend it's clinical care, I'll buy it. But in general, if the patient has always had a negative double-stranded DNA and always had normal C3, C4 annually for 3 years, and you see them and you don't see them with clinical disease activity, do not order. You need to actually spend thousands, many thousands of dollars of all this repeat testing to even find someone convert. That is different from they were positive, they converted to negative, and you're wondering about lowering therapy. Order tests because that might help your clinical decision. But if someone is serologically quiet and clinically quiet, I don't want to know what the serology does, but there are the exceptions to the rule are people that have been positive before or are really wondering about tapering or withdrawing therapy. So in general, that's it. And there we did publish on sort of the rates of the chance of converting is the opposite of what those things are. C4 stays the same 75% of the time, C3 83% of the time, and DNA 61% of the time. If you can justify it because you're doing a SLEDI for drug access, sure, do it. But if you don't have a reason to do it, just don't order tests because they're a lot of money and our brains are worth more. You'd rather get another consult than spend it on a lab. My opinion, controversial. Let's go on to one of my favorite difficult diseases is systemic sclerosis. Again, the patients consented, the many faces and hands of our patients. So we'll move back to Raynaud's. So the pearl here is basically if a patient has older onset Raynaud's, and in the textbooks and in the papers, by old, I don't mean old, it's 40, 45, or 50. So you pick your own cut point. But if it's new Raynaud's, especially if it's complicated, like they've already had an ulcer, more severe, or they have other things like dilated capillaries, then you must pay attention to it. If they're 30 years old and their sister has lupus, but the patient you're seeing 30 years old got Raynaud's at 18, nothing else defined, she could certainly have an ANA because her sister has lupus just by family history. But if she doesn't have other stuff, don't investigate. So maybe New England Journal won't diss me this time. So this has been submitted. But anyway, this is my kind of workup of Raynaud's. So most people with Raynaud's don't need any tests. They need your eyes, your history and physical, and you can magnify with your phone. You can get a program that's called Magnifier. You don't have to have polarizing light, or you can just take a picture of nail beds with a nice steady hand and magnify it yourself. So if you want to do capillaroscopy, that's great, but most people in this room aren't going to be doing that, and we don't do it either. The Europeans love it. It's helpful for research, but dilated capillaries get us interested. Okay. The next thing is, so Vito's cohort is very early diagnosis of systemic sclerosis. So pre-scleroderma or people in the Vito's cohort are basically likely early limited cutaneous systemic sclerosis because they have Raynaud's, they have an antibody and one other thing. So they're on the spectrum. So in general, and this is important because patients we do see like this, if a patient has Raynaud's, they have about a 1 in 3 chance of getting a connective tissue disease over the next 5 years if they're centromere positive and or dilated capillaries. If they're in the Vito's cohort, they already have maybe dysphagia or a little bit of puffy fingers or something. So a higher amount, even up to 45, 50% will develop Raynaud's. But if you're just seeing, not just, but you're seeing someone with later onset Raynaud's, centromere positive, they're stuck with me for an annual follow-up and I cue them on other things that could occur. But you could look at it the other way around. If you have later onset Raynaud's and you're centromere positive and nothing else is going on, 2/3 in the next 5 years won't get systemic sclerosis or Sjogren's limited cutaneous systemic sclerosis. But the ones who get Raynaud's earlier in scleroderma are usually limited, mean 8 years before they get systemic sclerosis, limited subset. For diffuse subset, a nice pearl is they often start the Raynaud's within a year, plus minus of their other symptoms. So the captive audience of Raynaud's and antibodies is usually centromere, older onset Raynaud's, and they're usually going to become, if they become a connective tissue disease or LCSSC. Okay. And just some signs. So you can see those dilated capillaries macroscopically. You can see telangiectasia on the patient's lips, and you can see puffy fingers. So that's a little bit easier. Okay. So the next pearl is interstitial lung disease and systemic sclerosis can occur at any time. So it's highest in the first few years. It can be diffuse or limited. There's a nice presentation that was yesterday, looking at the U-STAR cohort and saying the limiteds, about 30% of LCSSC, limited scleroderma, will get ILD, and about half of those will progress over a defined time frame of about a median of 5 years. So not everyone will progress, but limited, you need to screen them as well. So really, that was the study that was just presented. They've published on some stuff too. What about pulmonary arterial hypertension? The pearl here is treat to a target. If you have a green light, you're pretty good on the variables of BNP, dyspnea, walk distance, echo. If you're pretty good, echo meaning no right heart failure or hypertrophy or dilatation, then they get 1 drug, but everyone else starts at 2 drugs, and you treat to a target to get high risk to medium risk to low risk. So they treat to a target just like our people that are our colleagues that treat hypertension and hyperlipidemia, and us treating RA. So they treat to a target, and it's changed survival. Sjogren's, just a couple things. The clinical pearl here, this is my opinion, and if you disagree, it's an opinion, but I'm going to give it anyway. Of course I am. You don't have to repeatedly screen all patients with Sjogren's disease for lymphoma if they're low risk. If there's no red flag, it is a waste of money. And trainees come to me and they say, well, I was taught that. And I go, but tell me the pretest likelihood of lymphoma and tell me the number needed to harm, because you're going to find ditzels in places you don't want to. In other words, some nodule that you have to follow forever and things. So there's nice publications of the risk. So basically low risk, they only have 0 to 2 of these features, medium risk, high risk. And so if someone has cryoglobulinemia, strongly positive RF, they have a LIP pattern on their lungs, and they have a great big gland that's chronically present, I worry about that gland going into something like multiple lymphoma. But you don't need to do this SPEP. I mean, it's usually a polyclonal gammopathy, not a cancer thing. You don't have to do stuff. Now, if someone has B symptoms, new night sweats, weight loss, crackles on their lungs when you auscultate, you're going to work them up. You'd work up anyone, but we don't need to waste the money. We can spend our time and money on better things. So I have tried to be opinionated with some pearls and just give also some normal pearls that aren't so opinionated. But I think there are many pearls in clinical practice, and we're going to move on to hear some other ones. So with that, I thank you.
Excellent talk. As a reminder, we're going to leave questions for the end of this session for both speakers to answer. It's now my distinct pleasure to introduce Dr. Wynne Chatham. Dr. Chatham is a recipient of the ACR Clinical Clinician Scholar Award and an ACR Master. After serving as both the training program director and the rheumatology clinical director at the University of Alabama at Birmingham during 35 years, Dr. Chatham relocated to Las Vegas to help establish the new rheumatology clinical and training program at the University of Nevada, Las Vegas, where he currently is professor of internal medicine and director of the rheumatology program and the Kirkorian School of Medicine at UNLV. Welcome, Dr. Chatham.
Thanks, Angela. And by the way, I agree with everything Dr. Pope said. When tasked to do this, I thought this was a bit of an oxymoronic task to try to impart clinical pearls to rheumatologists. So if I do tell you something that you already know, just understand that these are concepts that I've observed over the past year or two, which I think are commonly missed or not well appreciated, both in the general medicine as well as the rheumatology community. Having said that, I'll be knocked out of my socks if there's anything I say that Dr. Gaffo doesn't already know. So with that said, let's go ahead and cover the other aspects of rheumatology that Dr. Pope did not cover. These are my disclosures. The objectives here primarily fall into 4: recognizing presentations of crystalline and seronegative arthropathies, identifying treatment-related rheumatic and autoimmune complications, recognizing gastrointestinal presentations of some of the autoimmune disorders, and identify inflammatory and autoimmune disorders typically associated with neoplasia or immune deficiency. The references are embedded. So I'm going to talk about 10 to 12 case scenarios that I think illustrate these concepts that I wanted to review with you. The first is a 72-year-old female patient presenting with occipital headache.
Doc, I think you have to move to the next slide.
We're not moving here.
Yeah, no, it's up.
Oh, still, is it on there? Okay, great. This is a 72-year-old female patient presenting with occipital headache, shoulder and hip girdle pain. She's got some mild fever, mildly hypertensive, but with equal pulses in both arms and blood pressures. No bruise, musculoskeletal exam, limited neck rotation, no peripheral joint swelling, but bilateral shoulder hip rotation and wrist limitations. She has a high CRP and an elevated SED rate. So this is a patient that you might worry about, or the ER docs that saw this patient were worried about, and we were called to see her about getting admitted for treatment of giant cell arteritis. But that's not really what she had. So this is a patient who had a CT scan done in the ED. And so because of the limitations we saw in her wrists and her neck, we were wondering if this might just be pyrophosphate arthropathy. And as you can see in the CT here, she has a crown dens, and with the calcium deposits there.
This one might turn. Yeah. Just apologize.
Yeah. Right here, we see the crown dens. And so the concept here in the Pearl is that don't bark up the GCA PMR tree until you've ruled out other things, particularly in this case, CPPD. Think of PMR as a syndrome, not as a diagnosis, and you'll stay out of trouble with making those false impressions initially. The radiographic footprints of CPPD, remember, can be chondrocalcinosis, that you can see in the wrists and knees. You can see subchondral cysts at the hip, the glenohumeral joints, and again, the crown dens. Another problem is what relates to
What is the one here left?
All right, I got you. Okay, I got you. This is a 73-year-old male admitted to the hospital with signs and symptoms of mild heart failure and possible right lower lobe community-acquired pneumonia. Responded well to ceftriaxone. No fever until hospital day 3 with temperature elevations of 101 degrees that persisted through day 7 despite discontinuation of his antibiotics along with mobilization difficulty due to right lower extremity pain. His cultures were negative, but he had a very high CRP as well as a mild elevation in SED rate, and his infiltrate was resolving. So we were consulted, and we were worried that maybe this might be crystal-induced arthritis because of the joint limitations, and indeed he had chondrocalcinosis at the wrist and knee. And he did have a knee arthrocentesis that confirmed presence of urate crystals. So the pearl here is that when you see nosocomial fever, particularly in elderly patients, and they've had infection ruled out, more likely than not, these patients may have flares of gout or pseudogout. They can have a very high CRP, often with a SIRS phenotype. We had one elderly patient who actually went into DKA because of his polyarticular gout. So this could be very inflammatory. So just be mindful that when you see patients in the hospital that develop nosocomial fever, think about crystal-induced arthritis. We see this a lot. The next concept I want to talk about is sorting out seronegative syndromes. We have a 37-year-old female with diffuse arthralgia that's seronegative for rheumatoid factor CCP and ANA. She's a past medical history of fibromyalgia pain syndrome, but she also has a family history of IBD and psoriasis. So the point here is when we see patients that have diffuse musculoskeletal pain, before we label them with fibromyalgia syndrome, it is important to be sure we're not being fooled by something such as a polyanthesitis syndrome. You get a lot of referrals in for patients that have the label of fibromyalgia, but yet when we take a history from them, get their family history and examine them, we see that that may not be necessarily what the case is. So the pearl here I want to emphasize is A key joint to examine that's not in the usual enthesitis menu that's shown on the right there with the homunculus with all the enthesitis points. The IP joint of the great toe is a very good sentinel joint for seronegative spondyloarthropathy. If you have a patient that has significant tenderness in the IP joint of the great toe, you should really consider the possibility that that patient may have a seronegative spondyloarthropathy. So joint tenderness of that joint is the sentinel. If you see asymmetric, contiguous tender joints in one or more digital rays, that's often a tip-off for a seronegative spondyloarthropathy, particularly psoriatic disease. Whether they have frank dactylitis or not, if those joints in those distributions are tender, they may well have early enthesitis. If also on your exam, when you're palpating tender points in patients, you may also actually have fibromyalgia pain syndrome. But if those enthesal tenderness points tend to be more prominent than the other fibromyalgia trigger points on the muscle exam you do, perhaps, you should consider whether that patient may have early non-radiographic axial spondyloarthropathy. Okay, another seronegative syndrome relates to a patient who's 36 years old. She has persistent dry eye and dry mouth symptoms, and she's referred for possible Sjogren's. She's seronegative for all of that, including somebody that ordered an early Sjogren's panel. But when we examined her, what we find is that she's got a psoriatic plaque in her occipital area that she wasn't aware of. So the pearl here that I want to emphasize is you don't read about this a lot in the literature, but patients with psoriatic disease and perhaps other spondyloarthropathies not uncommonly have dry eye and dry mouth symptoms. I've just appreciated this a lot over the decades to know how many of my spondyloarthropathy patients do complain of this. So it may be an early feature that can antedate, obviously, clinical disease. Next issue has to do with what we often encounter in our patients with rheumatoid or psoriatic disease that are on TNF inhibitors. A 42-year-old female with a history of seropositive RA on methotrexate and adalimumab had previously remitted, returns prior to her scheduled follow-up, reporting her current therapy now isn't working. We examine her. She has no rash. She has normal ocular mural membranes, but she does have some mild swelling and tenderness over the PIP joints of her hands. Because she's been on a TNF inhibitor for a while, we do check an ANA, which it's not uncommonly going to be positive in patients on TNF inhibitors, but hers was present in a moderately elevated titer of 1 to 320. So the pearl here is just to remember that new joint symptoms in patients on TNF therapy may be an early manifestation of a drug-induced lupus syndrome. As I said, ANAs commonly develop in patients on chronic TNF therapy, but the majority of whom that get that will not develop drug-induced lupus, but it can occur. The incidence of this is estimated somewhere between 0.2 and 2%, with the highest reported patients are those that are on TNF inhibitors for inflammatory bowel disease. So you don't have to stop if for some reason you see an ANA that's been found in a patient that you have on a TNF inhibitor, but if they do have new symptoms and had previously been well controlled, you do need to consider that possibility and probably get them on an alternative MOA than a TNF inhibitor. All right. The next group of diseases I wanted to talk about are those that we sometimes use IVIG for. So this is going to be more of a management pearl as well as a recognition pearl. This was a 38-year-old male admitted with focal weakness in his distal lower extremities. He was suspected to have Guillain-Barré syndrome and was started on high doses of IVIG, 2 grams per kilogram, administered over 48 hours. Over the ensuing week, he developed non-blanching purpuric skin lesions with ulcerations, some of which were actually quite extensive. We were worried that he might have pyoderma gangrenosum. They were that severe. He also developed progressive acute kidney injury during this time frame, and we were called to consult on the patient. Labs were notable for a very low C4, although his C3 was normal. He had very high titers of rheumatoid factor, as well as a confirmed cryoglobulin, who was found to be actively infected with hepatitis C virus. He had an immunofixation electrophoresis, which showed an IgM paraprotein. Serologies for CCP antibody and ANA were negative. Also of note, we did check his hepatitis B status in the context of being hep C positive, and also because we were going to contemplate treating him with rituximab for this cryoglobulin syndrome, and his hepatitis B core antibody total was indeed positive, but he had a negative hepatitis B surface antigen. So what are we learning from this, and what do we need to worry about? The management pearl here I want to stress for use of IVIG is that before you administer it, be mindful that passive antibody transfer with IVIG can have some significant impacts. The main ones are assessments for hepatitis B virus reactivation risk with B-cell depletion. You may get a positive result, and the patient has never seen hepatitis B. So just know that you can have passive transfer of antibodies just from pooled sera that can carry antibodies to hepatitis B. It can affect your autoantibody assessments. So before you give a patient a big load of IVIG, be sure that you've done all the serologic testing you want to do, because you can get some false positives from passive antibody transfer. Importantly, what happened in this patient was that if you have a cryoglobulin syndrome or immune complexes that contain rheumatoid factors, if you give that patient a high dose of IVIG, you can actually exacerbate the cryoglobulin syndrome or the immune complex vasculitis. So just be mindful of this. If you have immune complex disease where patients also have very high titers of rheumatoid factor that might be a component of that immune complex, because just the loading of the IG can trigger a lot of additional de novo immune complex generation that can aggravate the disease. And in this case, it was severe enough to give him necrotic skin lesions as well as give him a severe cryoglobulin-induced glomerulonephritis, which he turned out to have. Okay, this next one isn't in the domain of autoimmune disease necessarily, but at least where I am in Las Vegas, we've got tons of orthopedists and PMR doctors in practice that pretty much attend to most of the OA complications in that community. However, we all have our own patients that have that may develop osteoarthritis. Just because you have that autoimmune disease doesn't mean you can't develop those complications. So one of the more common things that I've seen over the years are patients coming in with recurrent hip and knee pain. This was a 62-year-old woman, had a 15-year history of stable RA on weekly methotrexate, previously diagnosed OA, comes in with persistent right hip epidural pain and ongoing knee pain, but had not responded well to greater trochanteric bursa steroid injections and knee hyaluronate injections administered by some of the local providers. Her labs were pretty much unremarkable. On exam, she had some right trochanteric tenderness. She also had some functional leg length disparity, which is an important physical finding that doesn't get checked for very often, that I try to teach our fellows and residents to do whenever they have a patient coming in with hip girdle pain. Her knee radiograph showed medial joint space narrowing on the right, lateral joint space narrowing on the left. And so we sent her for PT modalities and exercises to correct the innominate rotation, as well as some isometric quad and hamstring exercises and some medial and lateral shoe inserts to correct some of the knee mechanics. And the outcome here was good. Her hip girdle pain went away and she had less knee pain. So what is the pearl here? Refractory hip girdle pain from either gluteal tendon insertion on the trochanteric bursa or trochanteric bursa itself is most often due to unrecognized and undertreated innominate pelvic rotation. So this is an entity where each half of the pelvis can rotate anterior or posterior. If my thumb is where the hip socket is, you can see how it can cause a functional leg length disparity, and you can easily detect this by just having the patient lay supine, line up the chin with the sternum, pubic symphysis, and ankle malleoli. If that's offset, and you can easily distract it, then that tells you that you've likely dealing with that. And if that does not get corrected, the patient is going to continue to come in with the hip girdle pain. So the pearl is to recognize that with that simple exam and get them into physical therapy for the modalities to fix that. Okay. We'll leave mechanics of OA now. Okay, postprandial problems. So this is a 36-year-old female is admitted with acute right upper quadrant abdominal pain. She reports for the past 3 weeks she has had epigastric and right upper quadrant pain associated with nausea and vomiting, with symptoms becoming predictably manifest 30 to 6 minutes after eating. She has an abdominal ultrasound, which shows gallbladder thickening, but no noted gallstones. She does have a positive Murphy sign during the exam. Her lab studies are notable for mild leukopenia. She also has some mild thrombocytopenia, hematocrit of 36. She undergoes an uneventful laparoscopic cholecystectomy. Pathology confirms absence of stones, but she has acute chronic inflammation of the gallbladder wall. Serologies, because of the leukopenia, these were checked. She had a high titer ANA, but with negative double-stranded DNA and normal complements. And she also had a high titer positive anti-SSA. And on review systems, she did report some dry eye and dry mouth symptoms. She subsequently developed some increased fatigue and symmetric arthralgia, and was eventually started on hydroxychloroquine for presumed early systemic lupus. So the pearl here is that acalculous cholecystitis may be a bellwether sign for underlying autoimmunity. It's not an uncommon complication of patients with SOE. The SLIC damage index recognizes this. So if they've ever had a cholecystectomy, they get points for gallbladder disease. It's also may occur in patients with Sjogren's, and it can also occur as a complication in patients with systemic sclerosis. And importantly, this can often antedate the diagnosis of these disorders. Also, it's been noted that the majority of acalculous cholecystitis is not really in the setting of acute critical illness, that it often been the dogma that this usually occurs in just severely ill patients. But that's been shown to not necessarily be the case. Most cases of acalculous cholecystitis, when you look at registries, are done as outpatient type procedures, not in the context of a hospitalization for an acute critical illness. Okay, another similar scenario, a 22-year-old female presents with recurrent nausea, a 15-pound weight loss over the past year due to food avoidance. She's noted to have postural tachycardia and is also noted to have a positive ANA. Because of the food avoidance and nausea postprandially, she underwent a gastric emptying study, which showed significant delayed gastric emptying, 70% retention at 2 hours, 40% retention of the meal at 4 hours. Serologies were otherwise unremarkable, except as part of the workup for the suspected dysautonomia, she was found to have high titer SSA as well as an elevated titer of ganglionic acetylcholine receptor antibody that can sometimes be seen in patients with autoimmune dysautonomia. So the pearl here is that neuromyenteric enteropathy may antedate other clinical manifestations in patients with Sjogren's, and this has also been shown to occur in some patients with lupus as well as systemic sclerosis. Okay, moving to vasculitis. The one pearl I wanted to emphasize relates to what can be associated with IgA vasculitis, particularly in patients over the age of 60. So this was a 66-year-old male who had non-blanching purpura on his distal lower extremities. He had been otherwise been in good health without other antecedent illnesses. On urinalysis, he had some mild proteinuria and microscopic hematuria, and he did have some mild creatinine elevation at 1.4 milligram per deciliter. Skin biopsy as well as a renal biopsy were confirmatory for IgA vasculitis and IgA nephropathy. At that time, he underwent a chest, abdominal, and pelvic CT, which were unremarkable. However, a year or two after this, following treatment for the flare of IgA vasculitis, he underwent another surveillance CT scan 18 months later, which confirmed the presence of a 1.5 centimeter right lung nodule, which was PET habit. This was surgically resected and was found to be an adenocarcinoma. So the pearl here relates to IgA vasculitis in the absence of an infectious trigger. In an older patient, it has a very high association with malignancy. Most commonly, these are urogenital tumors or non-small cell lung cancers. They can also have oropharyngeal squamous cell carcinomas have been reported with this. Importantly, the IgA vasculitis very often antedates the cancer discovery, and this can occur by a time frame of 1 to 3 years before a cancer is discovered. The highest risk for this is going to be in older males. Okay, also related to syndromes we may see in some of our elderly patients. This was a 71-year-old female with persistent fevers, anemia, and thrombocytopenia. She had elevated liver chemistries, recurring erythematous skin rashes, as well as cervical adenopathy. Her past medical history had been pretty much unremarkable. She had negative cultures and a normal chest x-ray in terms of trying to find the cause of the fever. Abdominal ultrasound confirmed normal liver and biliary tract, but she did have some splenomegaly. And she underwent a bone marrow exam, which would be appropriate in this patient, which basically just showed normal hematopoiesis. White count was elevated at 15,000, but she did have some mild thrombocytopenia. Along with the liver function abnormalities, her LDH was elevated. She had a very high CRP and a significantly elevated ferritin. So this was a patient who was suspected to have evolving macrophage activation syndrome. She actually would have met criteria for adult Still's disease. But with the lymph nodes being prominent, she did undergo a biopsy of this, which showed a follicular B-cell lymphoma. So the pearl here is if you see macrophage activation syndrome or secondary HLH phenotype or a Still's phenotype in patients over the age of 60, it's actually been shown that the majority of these patients are going to turn out to have a malignancy. So the workup really should gravitate toward malignant HLH rather than just a secondary HLH. Moving to another domain of autoimmunity where we see this in the context of recurring infections. This was a 32-year-old Caucasian female who was referred in for recently noted positive ANA and elevated anti-SSA in the context of symmetric arthralgia and left limb paresthesia. Her routine laboratory studies have been normal in terms of CBC blood counts in urine. But because of some of the paresthesias that were confined to one side of her body, she underwent some MR imaging by a neurologist, which confirmed the presence of some demyelinating lesions in the brain as well as her C-spine. Her past medical history was notable for an episode of ITP at age 28 with a favorable response to Decadron pulse, and she also had a history of recurrent bronchitis. Chest CT showed significant bronchiectasis, and immunoglobulin testing revealed that she was significantly hypogammaglobulinemic. We also, in the context of recurring respiratory infections and bronchiectasis, checked to see if she might have mannose binding lectin deficiency, which she did. Complement levels were otherwise normal. So the pearl here is that assessment of respiratory infection history can be very informative in assessing patients presenting with autoimmunity. When I was at UAB, we had what we considered this CVID or common variable immune deficiency triad. If they had Anglo ancestry and they had frequent airway infections and autoimmunity, these patients for certain needed to have at least their immunoglobulin levels checked because very often we would find them to be hypogammaglobulinemic or they have even low normal IgG. You would be concerned about this possibility. Also recognize that opsonin deficiencies confer an increased risk of lupus. So if you have mannose binding lectin deficiency, that can be a risk for lupus, as can deficiency of C1q. Finally, patients with polyautoantibodies we sometimes see in clinical practice. This was a patient who had a history of a purpuric non-blanching skin rash with overlying tense bully, cough, and exertional dyspnea. Medication history, we found that he had hydralazine used for 2 years for hypertension management. Long story short, he had multiple autoantibodies to ANA, P-ANCA with positive anti-MPO, elevated anti-SSA, as well as positive antiphospholipid antibodies. His skin biopsy showed epidermal dermolysis with perivascular lymphocytes and eosinophils. So this is a patient who had drug-induced lupus as well as ANCA disease in the context of hydralazine use. So just remember that certain genetic causes can predispose to autoimmunity. We talked about CVID in the previous case. Some of the monogenic interferonopathies can do this, as can the autoimmune lymphoproliferative syndrome in patients that have fast gene mutations. But there's also important epigenetic causes of this, whether it be drugs such as hydralazine or chemical contaminants that some cocaine users may be exposed to with regard to levamisole can often induce this. And some patients that have organic solvent exposures that can inhibit the function of the autoimmune regulator protein, which impacts the development of Treg cells, can also develop recurrent immunity. All right. Thank you for your attention. And I guess we'll take this question.
Well, I'd like to thank our speakers for those insightful presentations. And now we're going to move on to our live question and answers. So this is your opportunity to ask. Please utilize the question and answer feature to submit your questions, and we can try to answer as many as we can. And we actually have one already in the chat, and it's coming from a generalist primary care provider whose lab is currently switching all ANAs to direct ANA rather than an ANA by IFA, and she's no longer able to get the titer or pattern. The question is, are there any pitfalls of a direct ANA that she should be aware of, and any potential for false negative? She wants to try to keep her referrals appropriate.
So if I start with this, first of all, thank you for attending, because we love when someone is attending where they're not a subspecialist to learn some pearls. So very, very relevant question. So I'll answer, and then Walter might actually correct me in a good way, but I asked chat one of the questions came up. So because I wanted to compare basically our indirect immune fluorescence, which we're used to, and then the solid phase, the ELISA, that's the direct. So the sensitivity and specificity can be different. So if you're doing your indirect, the immune fluorescence, lower specificity, so more false positives. The other one, though, could have some false negatives, so higher specificity, but it's not as good for all the antibodies. I think nucleolar might be one of them, but chat didn't tell me that. So you can miss some relevant antibodies in the solid phase, the direct. You don't get the pattern, and you don't get the strength. You might get the strength, though, in some things. Sometimes they'll call it like it's one is less than one negative, 1.2 is borderline, and then, greater than 3 is quite positive, etc. So sometimes they'll do that, but they won't give the pattern. There's some subjectivity on the immune fluorescence, whereas the direct are very automated. So it's almost like using AI, that they can actually be automated and help. So that's what I think would be the differences. You don't know the strength. You might miss some stuff, but you're getting, in a way, less false positives when you move to direct. Would that be any other things, Walter? Because that's more or less what I thought, and what Chat GPT kind of confirmed.
Yeah, I think the real message to understand is that the immunofluorescent ANA will encompass a wider range of nucleoproteins. When you do an ELISA assay, you have a limited number of fixed nucleoproteins that are stuck on the ELISA well. So particularly patients with early lupus, they may not have generated significant high titer affinity antibodies that would necessarily react in the ELISA platform, but these may regularly show up on an immunofluorescent assay. So I would say that if you're asking the question as to whether a patient with certain symptoms may be developing lupus, you would really want to use the immunofluorescent assay to address that. And if that's positive and you want to know what those specificities are, then you can go to the multiplex platform. Probably the best one-shot way to do are algorithmic assays that most of the reference lab offer, where they'll do an initial immunofluorescent ANA, and if that's positive, they'll then reflex that to the multiplex platform. But you do get a lot of false negative results with the multiplex platform, and the reason for that is that patient just may not have developed significant autoantibodies to the epitopes that are in that well.
Okay, thank you very much. Don't see any other questions. I have a couple of my own that I jotted down from my own clinical practice, and I was hoping to pick your brains. Dr. Pope, in your presentation, you had a patient who had malar rash, and you went through kind of differential list of things that can also lead to malar rash. So what clinical parameters do you use in your own practice? Because I find patients coming to me and they always say, yes, I always have oral ulcers, alopecia, and I have the butterfly. Everybody just kind of, says that across the board. So what clinical things do you use to try to distinguish between a malar rash of lupus versus, say, like rosacea or polymorphic light eruption, solar urticaria?
Right. And also, I mean, we do have some inflammatory myositis that get a rash across their cheeks and sometimes on the bridge of the nose even. So when they have other rashes like heliotrope and perhaps a cape-like rash, etc. So I think the first thing is I'm going to go back to first principles. Everybody's lost hair if they brush their hair or regular hair loss, men and women. So because since you said that and oral ulcers, I'll quickly answer that too. So the first thing is hair loss is untoward. There are times when you shed iron deficiency, postpartum stress, etc. But I always say this is more a clinical pearl that if I go through the hair and not hitting a knot, but go like that and just go through the hair. If I'm getting 2 or 3 hairs each time I do that on a patient, that's not normal. And hair loss on their pillow, like they wake up in the morning and they have strands of hair every morning, not normal. If they're saying it's plugging up the shower and it's always in their brush and their ponytail's thinner, that could all still be normal. So we mean by hair loss that it's untoward and atypical for the compared to the general population. For oral ulcers, I don't know a single adult and probably most kids as well who have never had an oral ulcer. So the ACR criteria used to say often painless. My experience is many oral ulcers and lupus are actually painful, but they're witnessed, they're often multiple, they're recurrent, and we don't have other reasons because there's benign aphthous ulcers in many people. Plus, after Halloween, eating a bunch of candies, like after the ACR was at almost at Halloween, people are maybe are eating lots of fruits or tomatoes or whatever. Oral ulcers can occur. So you want them to be more than the general population because again, it's pretty non-specific and there's a lot of benign reasons for that. So when you're going to look at looking at malar rash, it should technically spare right here, the nasolabial folds. It's not just pink cheeks when somebody's like flushing, they're especially a fair-skinned person that, they can look like the soldier with the pink cheeks that you've seen sort of stylized. That is not a malar rash. So malar rash would be something, it's often painful. It can be warm because it is inflammation. It's fairly superficial, so it shouldn't scar. Discoid can scar, malar rash should not scar. You can get pigmentation with it after it, but that's pretty unusual. And it doesn't have to cross the bridge of the nose, but it's the distribution it keeps. It can also be accompanied on your chin, on your forehead, like one of the pictures of the lupus man, the poor young man with lupus. So that's what I would say. And then we're not going to biopsy a cheek in general. Like derm will sometimes do a biopsy elsewhere on the face if they think that it will be helpful. Walter, I'll punt it over to you. Do you have any other words of wisdom in that?
You covered it, Janet. Nothing to add to that.
Good, thank you.
Great. Thanks. There's another question that's popped up in the chart, and Dr. Chatham, probably you can take this one first. So, male patient with SLE, positive ANA speckled pattern in a high titer, positive anti-Smith, lupus class 5, no skin or joint manifestations, and has been compliant with triple therapy. He always has negative double-stranded DNA and normal complements, and completely asymptomatic besides proteinuria. How do I approach this patient to evaluate for flare-up or active disease, given the fact that he has normal double-stranded DNA and complements all of the time?
Yeah, so you're not going to necessarily get serologic clues if those things were negative at the time of this nephritis being confirmed and diagnosed. So really, this boils down to having a well-educated patient to know what other signs and symptoms of a lupus flare might entail for him, should he develop additional manifestations. Now, if he's on triple therapy, I think that's unlikely to happen going forward as long as he stays on therapy. But just to report, new skin rashes, new joint symptoms, and just surveillance. I mean, anybody with lupus nephritis that we follow, I just tell them for the rest of your days, you should get somebody to look at your urine and you should keep track of your blood pressure and you should get that urine looked at least every 4 months, as well as have your blood counts checked. So um, it's just going to be surveillance for lupus flares like you would if they were serologically active. You just won't get the advantage of seeing that being predicted by, complement levels that are starting to go down if that's not part of his phenotype. So, um, yeah, I think that's about as good a job as you can do until we have well-validated biomarkers for being able to predict this a little bit better, other than just.
Right. And I fully agree. And this is the kind of patient that there's no point. You might do it for a bit, but there's no point repeating the clinically quiescent and serologically quiescent patients' complements and DNA because they were never positive as far as you could tell. So the chance of that helping you determine a flare is like zero, but also doing it every 3, 6, 9, 12 months is also a waste of time. And we do pay a lot of attention to microalbuminuria, and obviously red cells. You're not usually lucky enough to find casts unless if you're at a nephro center or a lab that's going to freshly spin and look. But you're looking for hematuria and proteinuria and even microalbuminuria that might adjust your treatment for the underlying proteinuria to lessen it, or to look further to say, down the road, does this person need a repeat renal biopsy? Because there's always 1.5 grams of protein per day estimated or proven, and ongoing red cells. After a year of treatment, if that was still the case, which hopefully it isn't in your person, then you'd probably say, do I need another renal biopsy? Or is this guy not adherent, or is there other reasons going on?
Perfect. Thanks. I have two other questions on Sjogren's. So, Dr. Chatham, in your presentation, one of the vignettes mentioned an early Sjogren's panel. What are your thoughts on that in general? Do you get those routinely? Do you think they're clinically useful? Should we do them? Should we not do them?
Yeah, well, the problem is those are yet to be validated as predictive of disease. I will occasionally order that if the patient has a Sjogren's phenotype and we think maybe getting early, that might be consistent with early development of Sjogren's, just to give ourselves a better idea about what it likely is, and that it's probably not due to other things. I think uh, people haven't really done rigorous cross-sectional studies that I'm aware of that would indicate that the extent to which those are present in patients otherwise that are seropositive for SSA antibodies, and meet all the formal criteria for that. So the role of those is still a little bit yet to be defined, but I think for patients that have some a presentation for symptoms that are otherwise unexplained and are not anti-SSA positive, then I do think sometimes getting that panel may be informative about how you're going to follow that patient going forward.
Okay.
You're going to
Okay.
keep them in your orbit. Yeah.
Okay. And then the second question is a patient who has Sjogren's with just dysautonomia, how do you approach the management of those patients? Do we immunosuppress? Do we not immunosuppress? If we are going to treat, what do you treat with CellCept IVIG? When do you pull the trigger?
Well, I'll go ahead and start with that, and Janet can chime in if she has additional thoughts about this. The dysautonomia itself, in terms of tachycardia and so forth, that's probably best managed how it is for dysautonomia that occurs in any circumstance, whether it's post-COVID or what have you. Just being sure the patient stays adequately hydrated, avoiding drugs that can aggravate the tachycardia, judicious use of low-dose beta blockers is probably the best way to manage that. The problematic dysautonomia really relates more to those patients that have significant GI dysmotility. As I said in the vignette, I mean, we can see this in patients with Sjogren's, we can see it in patients with early systemic sclerosis, and we sometimes can see it in patients with lupus. That may be more amenable to immunomodulation. And the success of doing that probably depends upon how long those symptoms have been present. For patients that have had this motility for a decade or more, I think we may be more getting into the damage domain where those things may not be amenable to immunomodulation. But we've certainly seen patients that have had prominent dysmotility, whether it's severe gastroparesis that's otherwise unexplained that are then found to have evidence of developing autoimmunity, where those patients have actually responded well to IVIG. And so I think in that circumstance, it's probably worth a try for those particular manifestations.
Thanks, Dr. Pope.
Yeah, I think to chime in, I think it's really tough. And because I see a lot of systemic sclerosis, everyone has dysmotility, whether they're symptomatic or not. You know, if you did manometry on their esophagus, et cetera, you're going to find changes. And I think part of the problem is that we're finding these things late. It's probably occurred subclinically years before, not months, but probably at least a few years, if not more. And so um, this is my opinion in scleroderma. It's different than Sjogren's and lupus, but my opinion in systemic sclerosis is that other than treating symptomatically, promotility, anti-reflux, et cetera, dilatation sometimes help, even if they don't have narrowing of the esophagus. I don't think most systemic sclerosis are going to improve on immune suppression, and even stem cell transplant stuff, the GI stuff usually persists, even though they could have improvement of ILD, improvement of skin, better lifespan, et cetera. I think in lupus and in systemic sclerosis, if we really think it could be early, and if it's kind of devastating, I try anyway for a while, but you need an end game. So if I'm going to try IVIG and lupus or a lot of, not a lot, but certainly there are Sjogren's patients with this that, as you heard about, that I think are under recognized for a while too, almost written off like irritable bowel and all that kind of stuff. But if you're going to treat, I usually say we need an end game. It's probably going to be subjective more than objective. And I think this is my opinion. I still might be stopping too soon, but if there has been zero improvement in symptomatology from 6 months of decent dose IVIG, it's probably a waste of time and stop. I have rarely tried because some of them also will have their ganglionopathy and Sjogren's or their rapidly ascending sensory peripheral neuropathy. I've also tried Ritux. I've rarely tried Cyclo. And again, I think I'm just getting in there too late usually.
Okay. Keeping on the scleroderma topic, because there's a question in the chat. For scleroderma patients, do you follow the modified Rodnan skin score? And what are your thoughts about skin biopsy to evaluate skin thickening?
Right. So, in general, you want some kind of validation in your chart on whether you think this is systemic sclerosis versus a mimicker. And you also want to somehow help to determine over time, is your treatment helping them or not? You also want to distinguish between a limited and diffuse. So because I am at a research site and we do clinical care and research on these patients, they've consented at the same time. I follow the modified Rodnan skin score because rapid progression is a bad sign. Starting really high is a bad sign. And conversely, an improvement is a better sign. Like if you improve 6 points over a year, that would be unexpectedly not the chance alone. There's probably a treatment effect there. So I do follow it, and because it is prognostic, particularly early, if your skin score is high or worsening and diffuse early, you're far more apt to get ILD or worsen ILD, and in early disease, the opposite. If you're improving or it's a low skin score, less apt to progress your ILD or get new ILD. So that's true, but later on when your skin might atrophy and the skin score going down, say 30%, 40% over many years, 4 or 5 years, with or without immune suppression, depending on the patient, ILD can still progress. So the skin score and ILD are concordant, and then later they do what they want. They're discordant. Skin biopsy, you shouldn't need. Now, where I could see a skin biopsy, like we do it for research, but that's not clinical care. But if you say, wow, this looks like eosinophilic fasciitis, they don't have Raynaud's, the fingers aren't involved, you can still have decreased flexion of your making fists because you're going to have tendons tight on eosinophilic fasciitis on the flexor and the extensor surfaces. But if there's no sclerodactyly, no Raynaud's, and they're tight and you don't know what's going on, you might want to do a biopsy at an area you think is active. We do have some generalized morphea patients for sure, but again, they don't usually, if you see enough scleroderma, they don't usually mimic because they don't have an ANA, they don't have Raynaud's, they don't have dilated capillaries, they don't have telangiectasia. But I would do a skin biopsy for research purposes, but for following clinically, it would be more, I'm stumped, I don't know the diagnosis. I have a few people with scleromix edema, pretty rare, and that's protein, not our collagen that we think of in systemic sclerosis. And they can't close their eyes right often, so their face is even more involved because almost all my patients with scleroderma can blink and close their eyes, even though they might have reduced oral opening. So scleromix edema is a tough one. I would probably get that biopsied. Walter, anything else to add?
Well, I think that's you've covered that quite nicely.
Well, Dr. Chatham, I'll pose the last question to you. In your presentation, you presented a patient with the greater trochanteric pain syndrome. Could you just very quickly review the examination that you teach your fellows to pick this up? Because I only
Yeah,
did part of it and I didn't get all of it. So I think that'd be
yeah,
helpful for all of us.
it's quite simple. You just have the patient lay supine, and you just line up the chin with the sternum, pubic symphysis, and the ankle malleoli. Try to get all that in a straight line,
Okay.
and then you just look to see if the medial malleoli are congruent. If they're offset, then something's askew. If they don't have any history that would tell you that they should necessarily have a leg length disparity, i.e., they did not have JIA, they did not have a previous femoral or tibiofibular fracture, and they have not had a previous hip or total knee or total ankle. Absent any of that stuff, they should be congruent. If they're not, then they probably do have rotation in the pelvis that's the most likely cause of that. So that's the kind of the screening test that we do. Now you can measure those anatomic lengths with a tape measure going from the anterior superior iliac spine to the respective ankle malleoli, but uh, that's a little bit tedious unless you think there's truly a reason they should have a anatomic leg length disparity. I don't usually do that, but if they've got that offset present when they're at the malleoli, when they're laying supine like that. Um, and you can sometimes see, you'll see one, when they're laying supine, you may see one iliac crest a little bit higher than the other. I don't bring a level into the clinic to confirm that, but if those, that non-congruence is a pretty good rough assessment if that's the issue.
Okay. All right. Perfect. Thank you very much. So I think it's now 8:20 and we're going to start to wrap up the session. Before we do close, I'd like to remind you guys to complete the evaluation survey that will be emailed to you because your feedback is incredibly important to us and helps us to improve future programs. We do thank you for joining us. We thank our speakers for being here and sharing their expertise and answering your questions live as well. We hope to see you guys on January 24th for our next ACR Convergence Replay, Vaccines, Reproductive Health, and Complex Cases. Have a great evening and Happy New Year, everybody.